this month, what we're covering is chest trauma. I'm sure you've never seen chest trauma in your life, right? Never once. Not any of it. So whenever we have to give you a lecture, of course, we have to have learning objectives. So I'm hopefully going to hit these learning objectives, give you something to go off of. Chest trauma is one of those things that we see. Traumas are one of those things that happen. About a quarter of traumas are chest traumas, and those, depending on how bad they are, about 60% of them die, depending on what you're dealing with. Biggest problems with chest trauma, we got a lot of stuff through here, right? We got all those big things that, these are our big things that we need to protect. Those lungs and the heart covered in there in that chest cavity. So you cause any problem to those two, the lungs or the heart, you've got major problems, and you're going to be working a lot harder than you wanted to with this patient. So it impairs ventilation, oxygenation, circulation. Remember, those two work together, right? If we don't have the lungs bringing oxygen in and sending it to the cardiovascular system so that we can get oxygen to our body, we don't have perfusion, big word Brent loved, and therefore our body's not going to do well. So we need to treat those right away, going way back to the ABCs, right? I think we learned that once. If we don't have a good airway, if we don't have breathing, we're not going to have circulation. So there's different mechanisms of chest traumas that we're going to see. Blunt. I always think baseball bat when I think blunt. I must have had a few of those when I was working. But those are also your MVCs. Those are the motor vehicles. These are the ones where Newton's law, remember, an object in action stays in action until it meets with another force, but then everything else also has to stop at some point, right? It's got to hit a force. So that's why you have those blunt traumas. Crush injuries are another part of that. And we'll hit on crush injuries just a little bit. Penetrating, that's whenever you have open, right? Blunt closed, penetrating open. So these are your gunshot wounds, your stab wounds, impaled objects, nothing you've ever seen, right? So when we talk about that, this one's one of my favorites, actually. So penetrating trauma, can you see that, what that is? How big of a knife do you think that is? To me, that looks like almost like one of those military knives, right? I forget what they're called, but somebody knows it. I'm sorry? K-bar. K-bar, you got it. This one's kind of fun because that's pretty cool. So, can you guess where that knife is? That looked like a heartbeat, right? So, we have a penetrating trauma. We have that knife right in there stabbing into there. And then we have also a penetrating one over here. And look in between those two. Which one looks like it's worse? Probably both, right? Probably both worse. But which one's going to get your attention more? Definitely if you're watching a knife do this with the heartbeat, right? Like, oh, cool. So let me take a picture of that. But the other one doesn't look like much, but we're missing a lot of things with that, right? How far did that object penetrate? What was it that penetrated? This knife makes it really easy, this K-bar. You have a good clue. If you've ever seen a K-bar, you know I've got a knife that's probably about that wide going in and sitting right there next to the heart. The other one, we're not sure exactly unless we can get the story of what it went in. And it's kind of hard to tell on this one what that is. I can't tell if that's a stab wound or a bullet. I think it's stab wound. Could be wrong. So the thoracic anatomy is one of those things that we need to kind of have an idea of. When you talk chest trauma, we're lucky because we do have the sternum, we have the ribs that help to protect, right? We have things in place to try to keep these areas as protected as possible from all the wonderful things we do and our patients do when they go hold my beer and do something. And works in conjunction with the heart. You got to get the oxygen in, you got to get the oxygen circulated. So the two work together quite a bit. We've talked about that in the past in regard to respiratory issues, right? We talk, is this a cardiac wheeze or is this a respiratory wheeze? What do we got going on? And they work very closely together. So that's things we have to look into. But our lungs are responsible for ventilation and respiration. Two things that we do without thinking about, right? Autonomic nervous system. If we think about it, we can control how we breathe. Kids, two-year-old kids maybe hold their breath till they reset because they pass out, if they're that committed to it. So there's various things that we have to look at. Perfusion of organs and organ systems is very important, and getting that oxygen through, very important. So one of the things, this is probably one of the hardest parts for a lot of people to understand, and maybe you guys got it, I hope you do. The pleural space. Why do we have a pleural space and what is it? And we have the visceral pleura, which the visceral pleura covers the actual lungs. And we've got 2 lobes here, we got 3 lobes over here. Parietal pleura lines the chest wall. And then we have the pleural space, which is in between those two. And it works really kind of in a neat way in which we have that, where we've got a fluid in that lining, so it makes things more lubricated. Think about it like if you put liquid between 2 pieces of glass. They kind of stick together, right? But they can move back and forth. And that's kind of what we get when we're talking the pleural space and how it works. These are the things, and it gets into a whole lot, and do we really care? We pass through our medic and our anatomy and physiology, but remember when we talked about how we have that negative pressure. And the reason this is important to have a clue on what's going on here is if we have a penetrating trauma or a blunt trauma into that, how is this being affected? Because this happens to affect how those lungs are going to be able to respond. That's kind of ribs we like, right? We have a rib cage. That's 12 ribs, and then we got the floating ribs down at the bottom, right? That sit there. Helps to protect things, helps to actually expand the area, cause that negative pressure so that then we can take a breath in and then release. So if we have an injury to this area, we might not be getting that oxygen in, so we have impaired oxygenation. We may not be breathing properly, too fast, too slow, not at all, our least favorite. We could have blood loss, depending on where that injury is, whether it's penetrating blunt and where that fluid inside or that blood is going. And we could have cardiac dysfunction. We start getting cardiac dysfunction, now we're really causing problems. And there's certain ones that we look at and go, uh-oh, we gotta work. Airway obstructions. Airway obstructions is your first. If you don't clear that, if you don't find a different way to get an airway, you're gonna be working real hard. Tension pneumos. You have air in the space that's hindering that ability to ventilate. Open pneumos, so that's when you have that open wound. Flail chests, we've got those broken bones. Talk about that. Massive hemos, hemothorax, and cardiac tamponades. So we're going to run over those. So in a pneumothorax, we actually have air getting into that pleural space we talked about, and it's interfering then. Because if you get air in there, you have just that little bit of fluid that's supposed to make things lubricate. Now we put air in there, and things aren't moving the same way. Eventually, it's going to cause problems with the breathing. So we have simple pneumo, tension pneumo, or open pneumo, all kinds of fun things. I bet we treat them all the same. We have a loss of that negative pressure. A lung can collapse. Wish I had a picture of that. We weren't able to get that for you. and reduced gas exchange. So we can't get that carbon dioxide out, we can't get that oxygen in as the body needs. And we're going to see certain things, no matter which kind of pneumo it is, we're going to see difficulty breathing, decreased breath sounds, probably some chest pain. They might say they're feeling a pressure or something. It feels like something's not right there. I'm getting a real pressure. Might be breathing real fast, and their oxygen level is going to start dropping. So in that tension, the air's in there, but there's no way for it to get out. That's one we can handle, right? We can do something about that. So the pressure builds in that thoracic cavity to the point that it makes that lung go, you know what, I got no space and I'm done. So then the lung can collapse, decreased venous return, shock, all those nifty things we're seeing. Now, what are we going to see with that sign-wise? We're going to see big respiratory distress. They are really going to be working to breathe. Blood pressure is going to start tanking on you. JVD. Anybody ever see JVD in the field? Not an easy one, is it? Unless you got them sitting at a right angle, the correct angle, about 30 degrees, and it looks kind of like a worm sitting there. They're kind of hard to see. If they're sitting upright, if they're laying flat, it makes it a lot harder. Tracheal deviation, that's another one that's kind of hard to see. When you think about it, how do you tell if a trachea is deviated? There's really, the only way you can tell is by that sternal notch. Follow that sternal notch up to the middle, and then both sides. Is it off to the side of that sternal notch? On either side. Those are the things we're looking for. And then absent breath sounds. That's probably the bread and butter. That's the ones that we're looking for more than anything, is they're saying it's a lot of pain, they're having trouble breathing, severe distress, and we listen and go, hey, I got nothing on the left side or the right side. That's really the one that we probably hit more than anything. What are we going to do for attention? Well, we got a couple things we can do. Oxygen's always our friend. Help them out with some oxygen. Needle decompression. And we're going to hit this in one of the stations in which we'll talk about needle decompression, because how many people have actually done one in the field? Okay, some of you, good. Glad to hear that. That's good. Sometimes you get there and people go, what? So needle decompression, we have areas in our protocol on the body, that anatomical spaces we're going for, right? What's the one that Doc likes better? You guys remember? He likes the fourth intercostal, right there, okay? Do you know where to find your fourth intercostal? If you don't, it's going to make it really hard to needle decompress, right? Got to know your landmarks, got to know your anatomy to know where you're going down to be able to find it in the intercostal space. State of Ohio has approved finger thoracotomy. Whether it's going to happen here or not, I don't know. That's up to each individual medical director if they say they want to try that type of thing or not. But what they'd seen is that there's, especially in some areas, where we're down to almost a traumatic arrest, and if we can do something real quick by way of a finger thoracotomy, stick our finger in there and release some of that pressure, we can get a patient back if we do it quick enough. So ears tuned on that one, we'll see what happens. Always an option. Rapid transport to a level 1. So open, sucking chest wounds. I love that. You ever get on and look up sucking chest wounds? If you haven't ever heard one, look it up sometime so that you can understand why they call it that sucking chest wound. See bubbling around it because you got air that's free flowing. So the air is moving through that chest wall defect. So where it's open, that air is going. So that's the open new, yes, we hit that, thank you. So you may hear a sucking sound as that air gets pulled in with the breath. Short breath, hypoxia, always. So these are the ones we talked about, occlusive dressings. We carry our occlusive dressings, right? You know where they are in your bag? Good, good. I go to some departments and go, where is it? And they go, give me a minute. So make sure you're aware of where it is. If you don't have that, what's the first thing you can use? That'll work, right? If not, anything that's not permeable, right? We can get that on there. Somebody's got saran wrap sitting right next to them after they got shot. Why not? Who knows? We've seen weirder things. We can stick that on there until we can do what we need to do. So we're going to watch for that tension pneumo. As it gets too much pressure in there, we're going to do oxygen, and we're going to beat feet. How about a hemothorax? Going over a hemothorax, we're changing air for blood. And you can have a hemopneumo. You can have both, right? But this one, now we're talking blood has accumulated in that pleural space, and where you've had just a little bit of fluid to cause that lubrication, now you've got a lot, and you can't get that same movement that you need to have happening. So, why? A lot of times the lung's been lacerated. The lung has been cut. You can have a vessel, a blood vessel in this area that has been cut. You can have a big vessel hit, and then you got more problems, right? Okay, where are we at? There we go. So we get decreased breath sounds with that. Probably looking shocky on you. Heart rate up, BP down, respirations up, right? We're seeing, we know these. We know these in our sleep. Difficulty breathing, dullness to percussion. How many people do chest percussion? What are we going to do? We're going to do the same things, right? Oxygen, IV, treat for shock, beat feet. Biggest things we can. How about a flail chest? How many's seen that in the field? That's a fun one. That's when you've got major broken ribs, right? You're not just broken in one spot, you're broken in several spots. So then things can't work in the same way. Remember, when we take a breath in, as we go in, the diaphragm drops, the chest wall expands, right? So, and we've got that negative pressure thing. So now you've got this that's unstable, right? Fractures are unstable, and they're unstable in a whole pattern where a whole section is done. So while they take a breath, it's going to be paradoxical movement. It's going to go in the opposite direction of the rest. So you got that free-floating segment. So that paradoxical movement, severe pain, this hurts. Respiratory distress, crepitus. Have you heard crepitus? Bone, bone, crunchy. Great sound. I'd prefer Rice Krispies. So this is about what flail chest looks like. That's exactly what this is. So when they're taking a breath, it's going the opposite direction. So what's the first thing we can do for that? Once again, a hand, right? Our hand, so the biggest clue, any kind of fracture, right, is stability. Doesn't matter where the fracture is. Unstable fractures are painful, very painful. So any fracture that we can stabilize is going to feel better, the patient's going to do better, things are going to be more in the right spaces to work, right? So same thing for this. So once upon a time, I've been around 500 years, I said, right? So we sandbags, IV bags, we do all kinds of things to try to hold that, to try to keep it so it would move in the same direction with the rib cage. So hand can work. You can put something else on just to give that pressure to try to keep it all in one piece. So what are we going to do? Oxygen, help them with pain management. Might need to do positive pressure ventilation. Watch your patient. Let your patient tell you what they need there. And rapid transport. How about that? If somebody has a flail segment, that's a pretty big injury. What did they take there? You know, maybe it's a 90-year-old who took a 90-mile-an-hour baseball right to the rib in the perfect spot. Not usually what we see, but it takes a good amount of force to be able to get a flail chest. So what about a pulmonary contusion? Contusion, bruising, right? We know this. Bruising of the lung tissue. Why does that happen? Baseball bat to a chest. We talked about a baseball bat to the chest. You hit them with that, it's going to cause damage. And it can damage that lung tissue. And it can make it so it's unable to work in its normal functioning level. Bleeding, edema. If your alveoli get damaged, they can't pick up that oxygen and they can't release that carbon dioxide, right? We've seen that with COPDers forever. You know, they don't have any good functioning alveoli, they can't make it, they're struggling. Same thing, these people are going to struggle. And what are we going to see? We're going to see low oxygen levels, difficulty breathing, crackles. Crackles are one of the key things. If you can hear crackles, that's something to think about, especially after a trauma that's a blunt trauma. It's one of those things to think about. Chest pain, I think my chest would hurt if I got hit by a baseball bat. What are we going to do? Hey, we've seen this slide too. Oxygen. We're going to watch for respiratory failure, ventilatory support as needed, and we're going to beat feet. Same thing. So, what if we're talking the heart as opposed to the lungs? The heart also has a sac around it that has just a little bit of fluid so things can move right. And that sac allows it to, the thump to be able to happen, the compression of the heart to move. Now what if you get fluid in that pericardial sac? Think about it. So it's supposed to do this. You get a lot of fluid in there. It builds pressure. How's the heart going to contract? It's going to have a hard time doing so. It's going to compress it. Beck's triad. I know we've hit that before. You guys remember what Beck's triad is? Blood pressure does what? Blood pressure down. JVD, yep, you might be able to see that. And the other one is muffled heart sounds. How many people listen to heart sounds? Sure. There's not many that do. Good for you. But the thing, if you do listen to heart sounds, you got to know what sounds normal so that you can know when something sounds abnormal. Okay? Muffled, it's probably not as, I wish I had a video of that. I would recommend doing a video on muffled heart sounds. So one of the things we're going to be seeing with that Beck's triad is you're going to see that narrowing pulse pressure, right? So they started out, they were 140 over 80, maybe now they're down to 120 over 100. You get that narrowing pulse pressure. JVD, muffled heart sounds, if you're listening for them. What are we going to do? Same thing, right? Oxygen, rapid transport. Let's get them there because there's nothing we can do. I don't think they've approved us to be able to put a needle in the pericardial sac and relieve the pressure. I don't think I'd ever want that kind of responsibility myself. But that's what the definitive treatment that they need is that pericardial sac needs to be emptied of that fluid. Rib fractures. How many people have seen their elderly fall calls go, right? We've all seen it. Guess what? They're going to keep going up too. And chest injury is one of the most common calls you're going to get. So possible complications, you get that pneumo or that pulmonary contusion with those. So people fall and they don't necessarily, especially if they're older, when they fall, they don't just kind of go, oh, let me go down. No, it's kind of like I go down. I have an uncle who's 91, and he went down with his arms like this. This arm in here was enough to give him 4 rib fractures as he fell. So it can happen. My mother-in-law, who's what, 90? No, she's 86. When she fell, she slid out of bed, was just enough to be able to break 3 ribs. Just being able, the way she fell was just enough to hit right on the ribs when she fell. Traumatic asphyxia. Anybody ever have one of those crush injuries? They were in something where something compressed them? Spud's Auto Parts. Working on a car with a jack, not a good jack. Car comes down on him, right on his chest. Asphyxiation right there, okay? I'm sure you guys all have other ones that you've had, same type of a situation. They happen because people don't always think things through. So it causes a severe compression of the chest. Things come down. If you do that, first of all, what can happen? You can't take a deep breath, can you? You can't make that ventilation happen. Cyanosis, blue is not a good color unless you're a Smurf. We've learned that over time. Petechiae, broken blood vessels from that compression can happen. And then that JVD, if we're lucky enough to see that. Commotio cordis, Damar Hamlin, Buffalo Bills. How many? I'm sure some of you were also watching the game and watched it happen and went, oh, that's not good, and watched it through. Commotio cordis, you hit right on that T wave, man, whatever it is, and you can make that heart stop. Often occurs in sports. We've seen it now in football. We see it. My sister had a softball player on her team that she did it in the batting cage. It can happen in many different sports, depending on, and it's just getting very damn lucky and hitting right on that T wave. So chance of it happening doesn't seem like it should be that much, should it? But it does happen. So these patients, we got to start all over, right? We got to get them CPR right away, early defib, airway management, oxygenation, ventilation, circulation, rapid transport. Yep. Damar Hamlin, even being a pro athlete who is in very good condition because he hit commotio cordis, he had cardiac arrest, he was in the hospital for a week. People go, why would he be he was healthy. Because if you think about it, any kind of pump sits for a minute, what kind of sludge do you now have going through and what are our electrolytes doing? And we have to get a full reset on the body to get everything where it is. All right? It doesn't happen overnight. It doesn't happen quick. Oxygen, high flow, you betcha. Ventilatory support, I can't even talk today, is what we're looking for. Now on to our fun. We can do needle decompression. And luckily, we now have these neat little kits that make it real easy to find that needle and be able to do it. It's a pretty big needle, isn't it? So we think about that. And I think that's one of the reasons Doc doesn't care so much for this so much. Depending on the size of your patient, the size of that needle, you have a little more forgiveness when you're talking mid-axillary than you are here, right? So Doc has us going in the best possible spaces to be able to do that. How are we doing it? Darts, right? We're doing our thing. We're making sure we find what? We're looking for the top of the rib because of what? Nerves and veins, you got it. Those are the things we want to avoid because we don't want to work harder. And we don't want to cause damage. Oh yeah, that's the other thing. So, trauma center. We're very lucky in the area. We've got our level ones, right? We got places probably very close to a lot of the places you're at and where these type of chest traumas tend to happen, I'm going to expect. You know, they don't call St. V's the Knife and Gun Club for a reason. I know that's one of your areas where you get to see a lot of the fun, a lot of the areas in that same type of area. Chest trauma can rapidly become fatal when you mess with the lungs and they can't do their job. By golly, you can die. Early recognition saves lives. You have to be able to note that. You have to make sure you're doing those ABCs and going airway, breathing, we got problems here. Let's treat this right now. And treat those life threats immediately.